The last video in this series touches on progesterone and anti-progesterone therapies. The objectives for this video are to briefly review the pathophysiology behind the conditions requiring progesterone and anti-progesterone therapy, as well as discussing the different medication formulations indicated in each condition. Chronic uterine bleeding is one area that you'll often see progesterone therapies. It's relatively common and occurs in approximately 10 to 35% of women. It can impact quality of life and cause problems such as iron deficiency and anemias. Usually, it can be managed in the outpatient setting. However, sometimes it can require hospitalization if it's severe enough. Today, we're going to focus our discussion on the outpatient treatment setting. There are two main types of chronic uterine bleeding that I'll discuss today. The first being abnormal uterine bleeding due to ovulatory dysfunction, or AUBO. This is essentially heavy menstrual cycles that do not occur every 28 days, so it's an irregular menstrual cycle. The thought is that it could possibly be due to unopposed estrogen and lack of ovulation. Whenever we have a patient who comes in with unusual but heavy menstrual cycles, we have to first rule out malignancy before coming to this diagnosis of exclusion. The second condition that we'll talk about today is heavy menstrual bleeding. This is regular menstrual cycles that are just extremely heavy or long lasting. This is thought to potentially be due to endometrial dysfunction. At this point, you should have watched the YouTube video on the nuances of the female menstrual cycle, but I just wanted to include an image here to remind you of the different hormones that come into play and why they may make sense with some of our treatments in the chronic uterine bleeding. The treatments for AUBO and heavy menstrual bleeding are relatively similar, but do have some treatment nuances. For AUBO, there's less evidence in terms of how we treat these patients, but in general, there are three first-line therapies. You can either choose to use cyclic progesterone, combined oral contraceptives, or a levonorgestrel IUD. In heavy menstrual bleeding, we have more evidence for different therapies in this area. In general, there are two main primary treatments and other treatments that you can consider. The two main treatments for this type of chronic uterine bleeding are combined oral contraceptives and the levonorgestrel IUD. You can also use NSAIDs such as ibuprofen 600 milligrams daily or tranexamic acid. And these two therapies would be ones that you could consider in patients who can't have any hormones at all. At this point, you've likely covered many of these medications in other lectures, but I'll review some of the hormonal therapies for these types of uterine bleeding. The first are IUDs, or intrauterine devices. As you saw in the previous slide, this is first line in both IUBO as well as heavy menstrual bleeding. With the IUD, they're not necessarily going to provide more regular menstrual cycles, but will rather be helping make the menstrual cycles lighter and therefore more tolerable for patients. The IUD that was specifically studied in this patient population was the Mirena, which is one of the levonorgestrel IUDs. It releases 20 micrograms of levonorgestrel each day. These are meant to last up to 5 years, but in the setting when being used for uterine bleeding, they may need to be replaced more frequently. So just something to keep in mind. This specific IUD was the only one studied in this setting. IUDs are a good option for patients with poor adherence because they're not having to remember to take a pill every day. It's also a good option for patients where estrogen is contraindicated because this is solely a progesterone therapy. The next medication that is indicated in the IUBO type of uterine bleeding are oral progestins. The two that are specifically talked about are medroxyprogesterone, and that's dosed 5 to 10 milligrams orally for 10 to 14 days each month, and then norethindrone, which is 5 to 15 milligrams, and that's a continuous dose throughout the month and a daily medication. Norethindrone is more potent than medroxyprogesterone. Side effects of these medications include bloating, increased appetite, and mood changes. This is an option for patients where estrogen is contraindicated, similar to the IUD. Um, it's important to know, though, that this type of dosing of the medication does not protect against pregnancies. So, if you're wanting to double use the medication for contraception as well as the uterine bleeding, this is not a good choice. The last medication that I'll discuss today are combined oral contraceptives. These can often be used as first line therapy for patients with AUBO or heavy menstrual bleeding, and we know that they can double as contraceptives as well. When we know that there are many different types of combined oral contraceptives, whether they're monophasic, biphasic, triphasic, as well as different types of estrogens and progesterones included in the different combinations. All types do appear to be effective. One thing that we have to take into consideration, though, when we're prescribing these medications are the days off from hormone therapy, which is generally the last week in a typical pill box. Um, when using for intrauterine bleeding purposes, generally the fewer weeks off that the patients are taking, the better, because this will mean that they'll have fewer menstrual cycles and therefore fewer opportunities for bleeding. So you could decide to do 1 week off every 3 months or just continuous dosing where the patient just takes an active pill every single day as opposed to taking those placebo pills throughout the therapy. One thing to note, though, is the longer that you go without taking the placebo pills, the more likely you are to have some breakthrough bleeding as well. All of the studies that were done looking at combined oral contraceptives and intrauterine bleeding were done with the oral pills, but depending on your patient preference, you could consider the patch or the NuvaRing if the patient does desire this. Lastly, I just have one quick slide on anti-progesterone therapy. Really, the main use of this medication is used for dilation and evacuation abortion procedures, and these are ones that are done in the second trimester abortion as opposed to earlier on in a pregnancy. Mifepristone is the anti-progesterone that's used in this therapy, and it's used to soften the cervix prior to the procedure. The dose is a 200 milligram tablet on day one, and this is used in combination with misoprostol. Adverse effects of this medication include abdominal cramps, nausea, vomiting, and a risk of vaginal hemorrhage. When using this medication in this setting, bleeding is very much expected. It's quite common to have for about 2 weeks, but can last even longer, up to a month. There, however, is a black box warning for excessive vaginal bleeding. So we should educate our patients that if they're going through 2 pads an hour for 2 hours or longer, they need to be seen by a healthcare professional immediately.